Good evening and welcome to this webinar on stroke rehabilitation. My name is Dr. Louise Johnson. I'm a consultant physiotherapist and I work in the National Health Service in the UK. I also run the Rehab Lab, which is a training company delivering evidence-based courses to physios and occupational therapists who are working in stroke and neuro rehab. And I'm joined this evening by Vicky and Colin. Vicky is a senior lecturer at Sheffield Hallam University and Colin is director of a private physiotherapy practice. And you'll get to hear a little bit from them and meet them in a while. So the plan for this session today, I'm going to give a short talk about current concepts in stroke rehabilitation. Whilst I'm focusing on stroke, a lot of what I'm talking about is really applicable to neuro rehab more broadly today. And I think stroke rehab is a really exciting field of practice to be part of. There's a growing body of evidence to help to guide us in best practice in stroke rehabilitation. And there are lots of exciting interventions now that we can be using to support people's recovery. There's also more evidence about the basic principles that apply across physical rehab and recovery after stroke, and I'm going to touch a little bit on this as well. So I'm just starting with a reminder of the basics, as this is the foundation for what we do in rehabilitation when we're talking about people's physical or motor recovery. So everybody will be familiar with the term neuroplasticity. This is the ability of the nervous system to change, and it's driven by what an individual does or what an individual doesn't do. So whilst I'm not giving a talk on neuroplasticity today, it is important for us to think about this as the scientific basis for some of the motor learning principles that we will be covering. And when we're thinking about designing rehab interventions, we want to be designing them to optimize neuroplasticity. So we know that this reorganization depends on training. Apart from in the very early phases after a stroke, it doesn't happen spontaneously. It happens in response to experience and use and training. And so those things are all essential to learning, which is essential to carryover and recovery after a stroke. At the bottom of this slide are some scans just to highlight this really. So these are functional MRI scans. They're showing what's happening in someone's brain as they are in an MRI scanner and performing some movements of their right arm. So the first picture is a control. So this is a healthy brain, and this is what we would expect to see. As somebody is moving their right arm, we're seeing the hand and the arm parts of the motor cortex lighting up in the brain. They're active. The second picture is somebody with a stroke doing the same type of a task. And in this particular individual, we are seeing activity around that same motor hand area, but we're also seeing patchy, spread out activity in other parts of the brain too. So this person is kind of drawing on lots of resource, including their left and their right hemisphere, to perform that movement. And the final picture is the same patient doing the same movement, but after a period of rehab and training. And in this particular individual, what we're seeing is much more brain activity going on. And some of that is in the area that we would expect, where the hand sits in the motor cortex, but some of it is also still spread across other parts of the brain. So it's certainly not normal, but what it's showing is that in response to rehabilitation, changes are happening in activity in the brain. And you'd see quite different things on this depending on the severity of stroke somebody has had and the position of it. So the question is, what can we do to drive these changes in the brain? What can we think about when we're setting up practice to ensure that we are giving the best opportunity for learning to be happening? And I'm going to just talk briefly about 3 different areas. I'm going to talk through priming for brain recovery. We're going to think about intensive and task-specific practice. And at the end, I'm going to really briefly touch on the importance of coaching and the role of a therapist in coaching and guiding somebody through this recovery. So priming refers to any technique that's delivered prior to or in conjunction with the main intervention with the aim of getting the brain in a state where it's most likely to form those new connections or strengthen the connections that are there. So the main intervention might be exercise or task practice. The priming activity would be something we're doing before or alongside that to maximise the benefit of that training. The aim is to promote neural and behavioural change. And the theory is that priming leads to an increase in neural activity before the motor training by getting the brain more excited, and that facilitates connections and long-term potentiation, so changes some of that kind of what's going on centrally in the brain. So it's kind of like getting the brain warmed up, getting it excited and ready to learn, so that when we practice the activity we want to learn, it's more likely to embed. And priming is a really promising strategy when it's used in the right way and combined with repetitive task training. Now, this table is just showing the types of interventions that could be used for the purpose of priming. And there are lots of different things, and a lot of them are things that you will use in practice anyway. You'd routinely use them as part of your clinical practice, but you might not be using them in the right way to achieve that kind of priming effect. So the top box are stimulation type activities, so things like repetitive transcranial magnetic stimulation, transcranial direct current stimulation, or transcutaneous vagal nerve stimulation. So lots of words there, but these are all external devices that can be applied either over the brain. Vagal nerve stimulation can be done through the ear, that provide input to the brain and increase excitability within the brain. These are not things that are typically used in clinical practice yet, certainly not in the UK. Vagal nerve stimulation, probably the most promising one. There's a lot of research happening around that at the moment. Next is sensory priming, so anything that's kind of giving sensory input that might increase the activity in those kind of sensory areas of the cortex. So something like TENS could be used for this purpose. Other priming techniques might involve movement, so they might include passive movements, which could be done with some kind of external device. It might be a general kind of cardiovascular type exercise activity like cycling or using a treadmill. And something we use really commonly in our practice will be neuromuscular electrical stimulation. So for particularly weak muscles, using cutaneous electrical stimulation to generate activity to give feedback to the brain is a priming tool. Motor imagery and action observation work in a slightly different way, but we know that within the brain we have mirror neurons. So these are neurons that become active when we think about or imagine or observe a movement in the same way that they would become active if we actually did the movement. So mirror therapy, motor imagery, action observation of either a skilled performer or of a video can be ways to help to prime the brain before practice. And the final category is pharmacological. So there are some drugs that theoretically might help to increase kind of neurotransmitters in the brain, again, to help with this kind of process of neuroplasticity. But there's less kind of clear evidence and there's no clear guidance for their use in clinical practice. So these ones in the boxes here, sensory, movement and imagery type priming techniques, are ones that are easy and safe and effective to apply, don't require specialist equipment particularly. And we cover all of these on our course. We think about how you might use them and how you might apply them as priming techniques in clinical practice. What's really important about all of these priming tools is that they are effective when they are done immediately before task-specific practice. So they're not standalone interventions, and they're not helpful if they're just done completely separately to the main practice. So what we are trying not to have is a patient just using them, as separate intervention at home and not then practicing the tasks that they're trying to learn immediately after. So that practice needs to be really close. That increase in activity in the brain doesn't last for particularly long. It's a boost. And so within 30 minutes, ideally a little bit less, the person then needs to be practicing the activity that they're trying to improve. So thinking about how we structure a training session and how we might use priming techniques within a training session is a really great opportunity for us to optimise the benefits of what we're doing then in that physiotherapy. So we've primed the brain, we've got it ready, it's all excited and it's ready to build its new connections. What do we then need to do? So there is good evidence that the best general treatment approach is task-specific practice, so functional and repetitive task practice. And quite simply, this means practicing the things that are difficult over and over again. But in reality, it's not as easy as that. So identifying what to practice and specifically how to do it and being really targeted in that requires really good movement analysis skills. We need to be able to work out exactly which parts of a movement somebody's having problems with or most problem with and where to start. We need to be able to understand the impairments that are causing that so we're targeting our interventions in the right way. And then find a way to train that at quite high intensity and repetitively, and then to build that back into the whole task or the goal that the person wants to achieve. And there's a lot of skill in all of that process. We need to make sure that that training is graded and progressive. So we're always looking at how we can make it more challenging for somebody and knowing when to progress that. We want patients to be working really hard, but there's a balance to be had. And that requires some judgment and skill as well. We need patients to be practicing actively. It's really important that it's the patient attempting the movement and not the therapist doing it for them. And in patients who are really very impaired or very weak, that's a real challenge. There might, of course, be some need for some assistance from a therapist to do that. But as much as possible, we want the patient to be active in the task. So we need to be creative in how we break that task down, set up that practice so that they can do that. Perhaps use other adjuncts to help it as well. And then we want to build in principles, known principles for motor learning that are effective, such as variability in practice, and to think about how we might use our instructions and our feedback to improve that learning process. And where possible, using feedback and instructions that are externally focused. So the patient is focusing their attention towards the overall outcome of the movement or the goal, not thinking too much about how their body moves, because we know that generates the automatic movement much more effectively. So in the video here, you've got somebody who is practicing a reaching task. He's assisting himself. He's working on kind of trunk extension and control at the same time. He's got a focus that's external on the board. He's got a target to move to. It's measurable. These are the types of activities that we would be building into somebody's exercise session. And all of this practice needs to be done at the right intensity. So this is one of the really important elements. And there's a lot of focus in stroke rehabilitation now on how we can achieve intensity of practice, because we know that that's an important element to drive those changes in the brain. But intensity itself is complex. It's made up of these different components, and they all kind of interact, and you need to balance them out. So frequency is about how often somebody might practice the task, so how many times in a day or across a week. Duration is how long that is, so how long a session is or a practice session is, whether it's with a therapist or whether it's a patient doing it themselves. And then within that length of time, repetitions is how many actual attempts of the movement the person does and how many of those are successful. And whilst there's not a magic number, we know that repetitions need to be high. We're talking about hundreds to thousands. So that's a real challenge for us to think about how we can achieve that or build up towards that with patients. But certainly what we do know is that having several exercises and doing 10 repetitions of each is not going to change the brain. On the right side of the equation is effort and difficulty. So effort is about the physiological effort, how much energy expenditure goes into the task that someone's trying to do. And we can measure that using a heart rate, or we can measure it using a self-reported scale like the rate of perceived exertion. And we want to work towards working patients quite hard, to moderate to high intensity in terms of effort. And then difficulty is how hard is that task for them to do, to actually achieve it successfully. If a task is too easy, then somebody won't learn. If the task is too difficult, then somebody won't learn. So we need to find the middle ground where there's enough challenge in the task for the person to be driving change in the brain, learning and improving, but it's not so difficult that they can't do that and they can't achieve it at all. So the therapist's role is to get the balance of all these different elements of intensity right. And one of the really important ones, as I've said, is repetition of practice. And we know that although there's not an optimal dose, it's going to be very individualized to a patient, and it might start quite low in someone who's really impaired. But we do know that all other things being equal, the degree of performance improvement depends on the amount of practice somebody does. Now that would apply to me or you if we decided to learn a new motor skill, a new sport, for example, and it applies in stroke recovery as well. So we need to find ways to help patients to understand that and to practice repetitions frequently at their kind of maximum level throughout the day. And one of the starting points of that is to count them, to record them, to set targets together and to review those targets. You can see a patient in the bottom here. I'm covering them up a little bit, but they've got a clicker, they're counting their repetitions and recording them on this sheet. So we will cover in the course a lot about how we might increase intensity in practice. It's a real challenge. All of our services in the UK, but across the world, have got limited resource. And this can't be all achieved in one-to-one sessions with physiotherapists. And it doesn't need to be either. So we can think about how we're delivering services, what needs to be one-to-one, what could be done in a group, what could be done virtually maybe. We can think about how we're counting, we're recording, we're monitoring intensity, and really importantly, consider what the person is doing, what the patient's doing outside of their sessions with us as a therapist. Are they empowered? Do they have the knowledge and the skills and the confidence to be practicing things themselves at home, to know how much to practice, to know how to adjust their practice? So semi-supervised, self-directed practice is a really important area as well. And we might think about technologies as well. So technologies provide great promise for how we can increase intensity of practice, how we might increase repetitions. And again, they're probably particularly useful in people who are quite weak and quite impaired and for whom it will be difficult to practice high intensity without them. So it'd be great for us to have discussions during the course about technologies that are available to you. They could be quite simple things, and what works and what doesn't work in practice. There's lots of work to do around technology. So finally, as therapists, we coach and we guide people through their recovery. The self-directed practice is as important, if not more important, than what people do in therapy. So part of our role is about giving people the skills to drive their own recovery and shifting our mindset from we do therapy to patients to we work with them so that they can make the best of their rehabilitation. We can support patients to engage by really listening to what matters most to them and thinking about, what kind of habits they have around doing home exercise and doing self-directed practice and working with that. We can think about how we can build their self-efficacy, a belief that they can improve with practice, because nobody does anything if they don't think it's going to help. We can think about how we build their knowledge around brain recovery, around stroke, their skills around what they can be doing and their confidence to do that. Partly we can do that through setting with them really specific and tailored exercises and agreeing targets for those and accountability. So whilst we cover a lot around what we can be doing as therapists with patients, a big element of that is how we're supporting patients to do as much as they can for themselves, to build that into their day-to-day, to really kind of drive those changes that are needed in the brain. And that might come a little bit later in people's recovery, but we would think about it from the outset. So in summary, therapy should start early after a stroke. We know that, and should focus on the practice of tasks that are used in everyday life. The brain best learns things that are familiar. It learns using familiar objects and in familiar environments. So we want to keep things as functional as possible, but that might not always be feasible very early in somebody's recovery. Therapy needs to be intensive and challenging. We need to tailor that for an individual, but for optimal recovery to happen, we need to think about how we can make it as intensive as possible. Repetition is a really important element of that intensity. More practice leads to better outcomes. It's easier said than done, and we can think about that a lot in the course. Patients should participate as actively as possible, keeping manual guidance to a minimum, unless the task is too complex or not possible without it. And we are not suggesting that you don't guide and support patients physically, but we're asking you to really think about when you need to do that and when you don't. What's the purpose of that manual guidance, and could this patient be being more active here? Information, so what we say to people in terms of instructions and feedback, can influence learning positively or negatively, and we can really tailor our communication to help this process of learning. And giving the person with stroke, the learner, autonomy can impact both motivation and their performance, and we want to empower people to be able to drive their own recovery. So this is just going into a brief little bit about the movement science course. We are really excited to be coming to Belgrade in October and running the full 5-day course for you. I'm just going to give you a little bit of an overview, but then there'll be a chance for you to ask us any questions. So it's a 5-day course. Day 1 is more of a theory-based day. This is where we cover some of the evidence and the theories behind motor learning and motor recovery after stroke, but we also start to think really practically about how those principles of recovery can be applied in practice. So it involves lots of group work, lots of discussion, some little tasks for us to do throughout the day, and it sets the scene for the rest of the course. Days 2 and 3 focus on reach to grasp, so we will be looking at the assessment and training of reach to grasp. Day 4 focuses on sit to stand, and day 5 focuses on gait. Very broadly, what we cover throughout those days are the evidence-based principles for motor learning and motor recovery, and importantly, how to apply them in practice. So everything is brought back to what do you do, how do you do this when you're with a patient in practice. We will cover the principles of biomechanics in relation to reach to grasp, sit to stand and gait. So we use a structured biomechanical approach to assessing patients and identifying movement abnormalities and impairments. We will think about common impairments and common movement compensations that we might see, why they occur, and use them to create a problem list. And then we will think about how and when to use a range of different interventions based on that problem list and that are grounded in an understanding of those components of motor learning. So you'll go away with lots and lots of ideas for practice. A little bit more depth of what we cover on day 1. So we will cover theories of motor learning and motor recovery. We'll go into much more detail about priming, why we might use priming, how we might do that, and some of the evidence. We will think about 6 principles of motor relearning after stroke. So we will think about specificity, graded practice, active practice, spaced practice, variable practice, and targeted feedback. We'll cover what those things mean, how you might use them in practice, and we do some little group work and some examples to sort of play around with the impacts of these different principles on your learning. And we will think about evidence around intensity and application around intensity. Our general focus is on delivering repetitive task training, how we might improve strength and coordination. We know these are the things that most affect somebody's function. And we will cover a little bit more about coaching patients through this to support their recovery. Some video clips on the slides from previous courses. Days 2 and 3, we move on then to really apply that in reach to grasp. This is Colin on the slide here. So we will go through an analysis of reach to grasp. We will use videos to do that. We will do some video case studies looking at patients with stroke and identifying common movement compensations, thinking about why those are caused. And we will work through different training strategies and how to deliver task-specific training, how to set that up, how to progress it. We do clinical workshops on these days with patients, and during those clinical workshops we will also have some time to think about some of those interventions that are specific to upper limb rehab. So thinking about sensory rehabilitation, electrical stimulation, mirror therapy, mental rehearsal, constraint-induced movement therapy. And whilst we can't go into all of those in lots and lots of depth, we can cover enough that if they're not familiar to you, you'll be able to go away and use those things in your practice. Day 4 is a similar structure, but moving on to sit to stand. So again, we look at normal sit to stand, use a structured framework to assess that. We will look at case studies and we will have a clinical workshop again. And day 5, finally is looking at gait. So we will use all of the same type of approach. You'll be really good at it by then. And we will analyse normal gait. We will look at impaired gait patterns. We will think about training strategies for abnormal gait, and we will have clinical workshops again with patients. You've got some previous course participants on the slide here working out some of the phases of gait using video analysis. So what will you gain? It's 5 days, it's a lot of learning, there's a lot of content, but we hope that we will have lots of fun in doing that. Vicky, Colin and myself will be delivering the course together, so you'll get input from all of us. We will be taking the research, taking the evidence and really pulling that down into what are the principles and how do we do this in practice. So you'll go away with lots of practical ideas, lots of strategies, things that you can immediately try and test and put into practice with your patients at the end of the course. You will also have a structured framework and a structured approach towards your analysis, which you might hone those skills that you've already got, and a structured framework for thinking about how you're going to direct treatment and how you're going to progress that treatment for people. And you'll be able to take those things away. We'll give you the resources and you'll be able to try those out in your practice as well. So we're really excited. We're looking forward to coming. We hope that lots of you will choose to join us. And we're going to stop sharing the slides now and have a little bit of time for any questions that you've got for us. Thank you.